I'm on the Surviving Sepsis campaign working group, so I hope that I'm in the right place to deliver this information. It isn't by any means a lecture, it's just possibly the best way to describe it is to demystify what happens when the patients that do develop sepsis end up in intensive care. So what goes on behind those folding doors. It isn't specific to neutropenic sepsis, so as you're the specialist, you can superimpose any additional knowledge that you've got on what I say and say, oh, actually for our patients that'll be worse, whatever. So it's just really just a skirt through the management of a patient when they come to us with a diagnosis of sepsis. Building on the things that other people have said during the day, the main thing that we've all got to take home is that we need to recognise patients when they're developing sepsis. That's the key. We can be as good can be at treating it, but if we don't recognise it early enough, we're on hiding for nothing. In-hospital mortality has actually decreased because we have got better at treating sepsis, so it's decreased from 28 to 18% roughly. Obviously, patients with cancer have a higher hospital mortality, and you'll know the reasons for that because of the white cell issues, mainly. But unfortunately, mortality in ICU is nearer 39 to 50%, so half the patients that either come to us or that we diagnose in the unit with sepsis are not going to make it. So it's not great. Once you get to ITU, things are on a downward trend. The consensus definition, you'll all know, didn't actually come about until 1992, so it's quite late on in the day. And then we had all these different categories of what might be happening, what might not be happening. Now this year that's been reviewed, revised. We've got a new definition that just sticks to sepsis and septic shock as a subset of sepsis. So it's sepsis, basically. If you end up with septic shock, you've got these additional components which basically tell us that your mortality is increased. So it's a little bit more straightforward for us to follow. The treatment, likewise, has been changed. As part of the assessment, we're now looking at sepsis-related organ failure assessment, which is not too dissimilar to the SIRS criteria that we had in the original definitions. But now we've got that infection as being the key thing, plus two or more of these other factors. Now, to get through the doors in ICU, you have to have something wrong with your lungs. You need respiratory support. So that's one of the factors. And then there's a whole variety of others. Deterioration in mental state, hypotension, in need of maybe medical drug management as well as fluids. Bilirubin, okay, so that's reflecting that the liver's compromised, but actually bilirubin is a biomarker that tells us that there's a severity to this sepsis. So it's quite an important thing to measure. Platelets obviously get consumed in the inflammatory process and also in the coagulation cascade, which is one of the features of sepsis that becomes uncontrollable as well. And then we've got our renal factors here that reflect that the kidneys are getting damaged and also lack of perfusion from the hypotension as well. So two or more of these factors plus an infection in our history, we're looking at a septic patient, which is what previous speakers have mentioned as well. This was the previous goal-directed therapy that was very detailed and that recently, since 2014, 3 quite large randomised control trials have deduced that it's not actually that effective. Okay. Although the treatment is based on this, roughly we are addressing things using the Sepsis 6. So early diagnosis up there, and then the main components, fluid resuscitation, delivery of effective antibiotics, so within that golden hour. Once they come to ICU, so these are probably improved outcomes in ICU, lung protective ventilation, which I'm going to go over. Judicious use of blood products, so not just throwing everything into a patient. Strategies to reduce nosocomial infections, so we'll go over that as well. and lactate levels, which were in the previous guidelines, but really they are not a one-off, let's treat that lactate level. We're looking at trends because they do parallel the septic shock severity, so we can use them as a mirror as to how sick the patient is. There are details of 3 randomised control trials, so they were across the whole globe, and they're in the reference list as well if you want some reading. Laboratory tests, the same as probably every other department, nothing unique there to intensive care, but quite a massive amount of blood chemistry looked at to deduce how bad the patient is with their sepsis. So once you've decided your patient's sick enough they need intensive care, probably for respiratory support, they come through the door, and immediately they come through the door we will be exposing them to these extra portals of entry for infection. So a bit like your goodie bag at a conference, when you come into ITU you get your own endotracheal tube and a ventilator, and they are portals of entry for infection. We also put intravenous catheter lines, central venous catheter lines in, peripheral lines if you haven't got them, and obviously a urinary catheter. So already we're making things a lot worse, unintentionally. Once they're in intensive care, we're building on the management they've had before. We're not by any means starting anything new, but the main things that we're fighting and that are challenging our management are the escalation of that inflammatory response. It's no longer a localised inflammatory response. We've now got this systemic eruption of inflammatory response. The endothelial cells of the capillaries start to release the chemical mediators that are going to cause vasodilation, which is the classic in sepsis, and also cause the capillary wall to become more permeable. Okay, so up until then, the endothelial cells have maintained, a good hydrostatic oncotic pressure to keep fluid in or let it out accordingly. Likewise with electrolytes, they've managed the coagulation cascade and the pro-inflammatory and anti-inflammatory responses. But in sepsis, we know that fundamentally that's what goes wrong, and all those cascades just get out of hand. We're fighting the systemic effects of that on the brain, the heart, the lungs, the liver, the kidneys, everything really. And when the patient gets to septic shock, we are really on the downward spiral because patients have got low cardiac output no matter what we put into them, drug-wise or fluid-wise, and also the lungs start to not work basically. And we're just going to go over some of the management strategies we have to use in order to treat these problems that are challenging us. So as I say, when you come in, you get your tube, you get your ventilator, off you go to your bed space. And then you would think that the ventilation was straightforward gas exchange. It's optimised that. But for optimal gas exchange, we need nice air-filled alveoli. We need a nice thin endothelial membrane to the capillary and epithelium to the alveoli. And we need a good blood supply. And in sepsis, we've got none of those. So our first challenge is gas exchange in the lungs. Okay, so it's not as simple as it sounds. In sepsis, we've got vasodilation, we've got leaky capillaries, we've got some of that fluid that goes into the interstitial space between the capillary and the alveoli actually leaking into the alveoli and effectively drowning it, flooding the alveoli with proteinous fluid that should be staying in the capillaries. So we've got fluid-filled alveoli. Those that are spared that are taking the brunt of our ventilation breaths. So we've got 2 lots of trauma there, volutrauma, atelectrotrauma. When you get the alveoli flooded with that proteinaceous fluid, it reduces the surfactant. So the normal thing that stops the alveoli sticking together is now gone. So in certain alveoli, they will stick together, and then you've got atelectasis, so you've got collapse. Coupled to that, we've got the compromise to blood pressure in the capillaries. And all the time, these systemic inflammatory mediators are going around and potentiating this, which leads to acute respiratory distress syndrome, which is our first big challenge. in intensive care. So where we've got alveoli that aren't flooded on the far side there, if you put a volume of air into them, they will expand and almost expand too much because some of the fluid that should be going elsewhere can't get there. The air will take the path of least resistance, and if it finds a nice clear alveoli, no fluid in there, it will try and get all the air into that. So we've got those sort of alveoli that may well rupture. And then we've got the others that may be in the more dependent areas where you've got that constant opening and closing and collapsing down, and they're also becoming flooded with the proteinous fluid from these inflammatory cascades and the cellular infiltration from the capillaries. And that we couple together and cause biotrauma. So our ventilatory mechanisms need to manage this marked respiratory decline or acute respiratory distress syndrome. If we look at this diagram, that side would be your normal alveoli capillary interface, and on this side we've got our ARDS interface. So we've got a bigger gap now for the gases to get across. So we've got poor oxygenation, and we've got a build-up of CO2 that can't get out of the blood into the alveoli. So our gases are already deranged. We've got some areas of the lung in the dependent patient lying supine there. We've got all these lower areas getting the atelecta trauma, repeated alveoli opening and closing, flooded with exudate. And we've got the ones in the less dependent areas where we've got scanty sort of areas of injury, but volutrauma and barotrauma is the risk there because the air is taking the path of least resistance. So how do you ventilate someone with those two sort of, this stuff down here needs bigger pressure, more breath, because it's got to force open rigid alveoli. The ones at the top are going, no, I'm too delicate. So how do you manage that ventilation? So what we have to do is reduce the tidal volume and the airway pressure so that we don't cause overextension of the non-dependent alveoli. Now, the patient could be in a different position. They don't have to be lying on their back all the time. I know some of you think that's how we nurse our patients in intensive care, but they're not all lying on their back with their arms by their sides. And we need recruitment strategies for these lower dependent areas. So we need some breath in, we need to hold that breath, and we need to breathe out, but not completely. So we need what we call PEEP, so positive end expiratory pressure. So we're going to open those alveoli and then not let them close completely. And at the top, we're going to give them a nice breath, but not too much. So that's how we manage the ventilation of someone that's developing or has ARDS. We do have waveforms on the ventilators, and what we're basically looking at is how restricted our alveoli are, because as they become more and more fibrosed, you can imagine they get a bit stiff, and that's where that recruitment becomes a problem, because you've got stiff lungs that you're trying to get air into. So we look at these waveforms and we just make sure that we're not too low in the curve, that we're not recruiting alveoli, that we're giving enough pressure and volume to open up those dependent alveoli. We're within the safe zone to give those alveoli that are less damaged by proteinous fluid and not over distending them. So we look at different waveforms on the ventilator and see that they're all where they should be. Oxygen therapy, and this is universal, not just unique to ITU, but the British Thoracic Society have said no one really needs saturations of oxygen above 94. Now, you could argue in sepsis we've got this hyperdynamic state, we've got hypoperfusion, we've got hypoxia. So if we give as much oxygen as we can, hopefully that'll address that issue. But what we have to bear in mind is that oxygen can be quite toxic to the body. Certainly renal toxicity, it can damage some nerves. So oxygen toxicity can produce convulsions or fits, or twitching at the least. It can also damage ocular components, and it's quite destructive at the cellular level. So with oxygen therapy, we give optimum gas exchange, but once we've got an arterial oxygen saturation that's reasonable, we do not pursue putting the oxygen up. Okay, so it's not possibly as straightforward as one might think. Now, we can't do this alone. Obviously, there are teams in intensive care, and the physios are very important, both for physiotherapy, positioning. We might use kinetic therapy, which is the beds that move, basically to try and keep that dependent area moving so that no one area of lung becomes so damaged that it's difficult to recruit that and for it to heal. So that, obviously, on top of everything else, is helping to improve our respiratory function. Now, nitric oxide comes in and out of vogue. Basically, we're talking about it being delivered inhaled nitric oxide, because nitric oxide is one of the chemical mediators that is released by the endothelium that causes all the vasodilation and permeability problems. So here we're talking about it being inhaled so that it purposefully and locally will vasodilate the capillaries within the pulmonary system, so to optimise oxygenation. And again, we're trying to recruit or make sure that we get air to the areas of the lung that are going to take part in gas exchange, and not those that are too collapsed, that there's no gas exchange going on. So basically, we may use that as a therapy as well. And the reason I put that up there really is we're adding up bits of equipment now. We've got a ventilator, we've got, nitric oxide. Basically, that's the picture of ICU. It's just a bed surrounded by loads of equipment. And that's another piece of equipment that you may see in the unit. Moving on to the haemodynamic management, which you could argue is the crux of the issue, with the vasodilation, with the chemical mediators causing permeability. We've got to make sure that we address several problems here. We've got the coagulation cascade going off willy-nilly, and so we've got lots of clotting going on. And those clots get into the microcirculation, the capillary beds, and start the multi-organ failure because they block the perfusion of organs and tissues. So we've got that going on. And we've got the vascular instability with the chemotaxis, so all those white cells that are being signalled to come and fight the infection, the complement system, the cytokines, all those things going off that are vasodilating, leaking, making the capillaries leaky. So again, difficult to manage. How do we monitor that high hemodynamic system? We don't any longer use Swan-Ganz catheters, which were quite invasive. We used to thread them through the right side of the heart so they sat in the pulmonary artery. And we got a bit blasé about that because we didn't put them in, the medics put them in. But they would say, can you just tell me what it's saying on the ECG? And we'd go, oh, it's all right, VF, yeah, VF, yeah, VF. And it became a bit blasé because as you obviously go through the heart, you irritate it, so it goes into lots of dysrhythmias. So it wasn't a great thing to put in, but once it was in, it gave us the pulmonary artery wedge pressure, which we could estimate both right and left side of heart function. Eventually that went out of vogue because it was damaging. Was it beneficial? Were outcomes improved? These new ways of monitoring came along, or newer waves. The transesophageal Doppler on the far side, which is basically a flexible ultrasound probe that we can put down the esophagus to the level of the descending aorta, and we can pick up the flow within the aorta. And we can work out from that things like stroke volume, cardiac output, systemic vascular resistance, and we can give our fluid therapy accordingly to make sure we don't overload patients that have got leaky capillaries, because if you put loads of fluid in, where's it going to end up? In those poor little alveoli that are trying to breathe for us, okay, as well as other tissues as well. So we like to monitor the fluid management. We can only do that obviously in an unconscious patient, because I don't think any of us would tolerate an ultrasound probe going down our esophagus if we were awake. And being left there. So the other thing we can use is LIDCO, which is attached to the central venous catheter and the arterial line. And the way we work out cardiac output here is monitor how quickly a bolus of lithium chloride injected into the CVC is picked up at the arterial line, which has got a sensor on it. So there we can monitor the same sort of thing, cardiac output. We can see responses to fluid management. So that makes it a bit more manageable. It makes our fluid management a bit more realistic. We don't give endless fluid because we're trying to fill up that vascular space because of the vasodilation. And we know roughly how much to give before we have to introduce something else into the equation to keep that cardiac output going. And invariably, the first line of response is noradrenaline. And we give that mainly because, although it's got alpha and beta components to it, the alpha components are the vasoconstricting, vasopressor components. So those are what we want. We don't really want the beta components, which essentially increase cardiac or myocardial workload and also have an effect on heart rate. So we use noradrenaline at low doses, but sometimes we have to go up to higher doses, and that's where we start to get more effects, side effects of this drug. Anyone that's worked with infusions of noradrenaline will know once one syringe is starting to run out, you've got to put the next one on. It's a juggling act. And you've got your colleagues standing there going, yeah, 6, systolic 60, 55, and you really don't need that. But you've got to switch the syringes over. So piggybacking infusions is an ICU nurse's competency, basically. The problem with noradrenaline, it can cause bradycardias. Obviously, if you give a slight bolus as you're changing the syringe, you might get a really profound hypertension. And because it's vasopressor, because it's vasoconstricting, we get that peripheral necrosis as well. So sometimes patients get, damage to their periphery, fingers, toes, etc., if they're on it long term. Sometimes we have to add in adrenaline, which has got more of the beta components. So we're starting to now increase myocardial oxygen demand, and in a hypoxic patient, hypotensive patient, that can be a compounding issue. Or we might use low-dose vasopressin, which has similar effects. So now we've got optimum fluid, we've got vasopressors on. We can't really go much further. With any fluid management, we need to know what's going in is coming out. So obviously these patients need a catheter in, part of the Sepsis 6. And we put that in to monitor urine output, don't need to tell you that. But more so to monitor renal function. So we could have a patient passing the adequate amount of fluid up there, or urine rather, but it's not good quality. So we have to not only measure urine output, we have to look at the biochemistry of the urine as well. Any abnormalities, obviously, we have to address by improving circulating volume and blood pressure and all the rest of it. But invariably, the patient ends up on another machine, which is the hemofilter. Now, this basically does the work of the kidneys when there's poor quality urine and when there's no urine output as well. So when the kidneys are damaged and when they're not being perfused enough, because they are the most sensitive organ with regards to blood perfusion, when they're not working properly, we need something else. So we get a large bore catheter put in. That's got 2 lumen. Blood comes out of one, wishy-washy around the machine, through a filter, which is the bane of any ICU nurse's life, because don't forget, I told you earlier, this patient's got clotting going on beyond belief. The coagulation cascade has gone mental. So that filter, with all its very tiny little pores, gets full up with the clots and will stop working at the least little amount. So the blood goes through, we can take off fluid, we can put electrolytes back or take them off depending on what the issue is. It does require a good flow, blood flow through the machine. So again, that's another problem. Vascular access in the critically ill patient is quite difficult because they're oedematous, because they've got vasodilation, then vasoconstriction. So that's a challenge in itself, but usually this is happening fairly early on. So these are within the first 1 or 2 days, all this machinery and invasive lines being put on. But once that's on, we can kind of manage the kidneys. So now we're working for the lungs, the heart, the kidneys. Clotting, I've already mentioned, it goes out of control. We've got lots of procoagulation, and what we've got is a declining anticoagulation pathway. So it's tipped, lack of fibrinolysis, loads of coagulation and inflammation. So we get all these microclots in the capillary circulation, causing end organ failure, and impaired tissue perfusion. What that does is basically over time it consumes all the clotting factors faster than the liver can produce them. So we have to replace them with either platelets if they're low, FFP and cryoprecipitate if there are clotting factors missing. But in the interim, the patient can start bleeding. So if it's used up all the clotting factors, the only thing to do is bleed. So we get these characteristics. Once we start to see the sort of petechial hemorrhages in disseminated intravascular coagulation, we really are thinking, we're not going to win with this one. And because we've got so many invasive lines, we've got the hemofilter in there, we've got the central lines, all the peripheral lines, anything else that's in, bleeding gums, all those sorts of things, the patient can bleed quite profusely. So managing DIC becomes another big problem. And all the while, we've got a patient lying there who's a real person who's got to tolerate all of this therapy and this management. And the other challenge to us is sedation and analgesia, just the right amount, because if we over-sedate, then we increase ventilation time, we reduce weaning, obviously hospital stay is longer. It's not good for a patient to be on a mechanical ventilator. We want them breathing on their own. And if we under-sedate them, then they become anxious underneath poor sedation, tachycardic, their haemodynamics start to become deranged, and we're trying to manage those. We have to monitor this and assess this on a daily basis and make sure that we're sedating the patient effectively. They've got to tolerate the endotracheal tube, they've got to tolerate all the large bore cannula that are in, and also being ventilated. So the sedation is always a bit tricky. And we always must make sure that we analgese the patient enough. So analgesia should be the first priority, and then we make sure that the patient is sufficiently sedated, and never use sedation without analgesia. Some patients we have to use neuromuscular blockade drugs to make sure that they really don't move much at all. And now we're talking more about the patients with traumatic brain injuries, where we're really trying to control so many systems that we just need the patient to be quite still. So sedation, over and under sedation, again, another big challenge in our patients. Nutrition, probably not too dissimilar to those of you that work in acute areas. We know that when patients are really ill, they become catabolic. In critically ill patients or ICU patients, we've got that breakdown of protein to give us the fuel for energy. So muscle wastage is a big problem. So we do have a dietitian that works within the unit that on a daily basis will work out the patient's requirements. It's never that's what they need for their duration of stay. It's on a daily basis. And those things change in the same patient from day to day. Obviously, if they've got an infection, nosocomial infection on top of that, wound healing, all those things, it promotes poor organ function. So we have to make sure that nutrition is given. And I'm just trying to think of the next point, which is obviously enteral nutrition is preferable, because abdominally, if you don't provide the gut with nutrition, the bacteria that live there will pack their bags and head off somewhere else. And whilst they live in your gut, they don't cause much problem. In fact, they're good bacteria. But when they hop on the blood bus and get to the lungs, they can cause infection. So we don't want any translocation of bacteria from the gut elsewhere. So we have to make sure that if the gut is working, that we give it nutrition via enteral nutrition. Might have to use a bit of parenteral nutrition as well as an enteral, but we have to make sure the patient gets that to avoid malnutrition. One of the things that goes hand in hand with this is management of glucose. When you get a hypercatabolic patient with sepsis, adrenaline and noradrenaline, endogenous noradrenaline and adrenaline from the adrenal glands will be released to try and release the stores of glycogen in your liver for energy. So you get a hyperglycemic patient. And hyperglycemia will potentiate that pro-inflammatory condition. So we need to get that under control so that we don't exacerbate the inflammatory condition, and that we can feed the patient effectively. And the body doesn't feel starved of energy and start breaking down muscle tissue. Okay, so reasonably tight glucose control goes along with nutrition, and that's another challenge within our management. So once we've got the patient on all these different machines, all our infusion pumps lined up, someone comes along and says, okay, we need to take them to CT scan, and you just go. Unfortunately, transfer of patients is a big killer in intensive care, or in critical care, as you can well imagine, because you've got to take those pumps with you, the infusion pumps, so all the batteries have got to be working. You've got a ventilator, so you need a portable ventilator. You need to take them off the hemofilter, which is messy sometimes. So there's lots of things you need to take with you. You need to get to where you're going without anything running out or falling off the bed or whatever. And then you've got to get them on the CT scanner, need I go on. There are lots of opportunities for tubes to come out, catheters to come out, IV lines to come out. So unfortunately, there is a mortality attached to patient transfer, and that's in hospital, not only when they have to go somewhere else to another hospital, for example. Most other imagery we can do on the unit, but again, it means moving the patient, and that can be quite a problem if the patient's very unstable. So that is basically a whirlwind trip through the management of the ICU patient with sepsis. My message to you is recognise it early and treat it early, and then they'll never get to us. And we'll only have the ones that we don't recognise early to treat. Because we do have quite a lot of abdominal surgery, and sepsis is related to abdominal problems more so than anything else, so highest mortality rate. But there are new definitions. There's probably more guidance on treatment and judicial use of fluid, not overloading a patient with leaky capillaries and drowning them, basically. So if we stick to those, where do we go with this? Is it the optimum treatment for sepsis? So that's the continuum. We need to recognise them early, and then we won't be on this downward spiral with the patient in intensive care. So thank you for listening. I'm aware the football's been on and the tennis has been on, so I was quite expecting to have just 3 people in the front row. So thank you for listening. I hope it was helpful, just a bit of demystification, and the research and references there.
Thanks, Deb. That was brilliant.
All right.
Really informative. Thank you for doing that. Are there any questions for Deb? I'm going to ask you a question.
Oh, right, go on then.
Do you know what is there any data about survival outcomes of patients that actually do go on to develop DIC? Do you ever manage to get any of those patients back? I'm just thinking of kind of experience of actually when you get to DIC, the patient's going to die.
I think, yeah, basically mortality rate goes up. I can't quote the actual figures, but it's nearer 80 or 90%. And those people in the audience that nurse patients at that stage know that once they reach the bleeding end of DIC, basically you are on hiding to nothing.
Yeah. If
you can catch them earlier, maybe.
The reason I ask that is just thinking about patients that are presenting neutropenic sepsis. The bone marrow suppression that is caused by chemotherapy, by systemic anti-cancer treatments, doesn't just affect neutrophils, it affects all bone marrow blood production. So thinking about your platelets in the first place, you're going to have reduced platelet count in these patients that are neutropenic. So they're already somewhere along the line towards having an increased risk of DIC. So I think that's a more common complication that will happen in a patient that's got a chemotherapy-induced neutropenic sepsis.
Yeah.
Are there any questions?
Stunned into silence.
It was wonderful. Thank you so much. Thank you.
Thank you.